All right, welcome back to the Trauma Therapist Podcast. My name is Guy McPherson. My mission is to help trauma therapists be their incredible selves, to be human, to be real, not just a clinician. I'm a big believer in who we are is more important than what we know. And this requires cultivating authenticity, genuineness, and vulnerability, and that requires intention. You can learn more about my courses and workshops by going to thetraumatherapistproject.com. That's thetraumatherapistproject.com. Let's get started. So 5, 4, 3, 2, and 1. All right, folks, welcome back to the podcast. I am thrilled to have as my guest today, Dr. Patricia Resick. Dr. Resick, welcome to the podcast.
Thank you.
You're welcome. So Dr. Resick is a professor of psychiatry and behavioral sciences at Duke University Medical School. Dr. Resick began developing and testing cognitive processing therapy, CBT, in 1988 at the University of Missouri St. Louis, where she founded the Center for Trauma Recovery and was an endowed professor. CBT is considered first-line therapy for PTSD in the United States and several other countries. The CPT treatment manual has been translated into 12 languages. Dr. Resick has served as president of the International Society for Traumatic Stress Studies and the Association for Behavioral and Cognitive Therapies. She is a recipient of Lifetime Achievement Awards from ISTSS, ABCT, and Division 56 of the American Psychological Association, among other honors. Dr. Resick is the author of the new book, Getting Unstuck from PTSD, Using Cognitive Processing Therapy to Guide Your Recovery. Dr. Resick, an honor to have you on here. Thank you so much for being here.
Thank you. Appreciate it.
You're welcome. So before we get going, share with our listeners where you're from originally and where you are currently.
I'm sorry, where I was originally?
Yeah, where you're from originally.
Oh, I grew up in Ohio.
Okay. And I'm guessing you're at Duke?
I'm at Duke. You can tell from my background.
I can tell from your background.
I'm currently at Duke, yeah.
Oh, okay, awesome. So let's start, if we may. How the heck did you get on this journey?
Yeah, people often ask that. I was on internship at the Medical University of South Carolina and the VA. And a couple of the people that I became friends with were in the process of setting up one of the first rape crisis centers in the country. This is in the mid-1970s. And they asked if I wanted to be a rape crisis counselor. And I said, sure, what's that? Because there was no such thing. And so I got the experience of getting up in the middle of the night and sitting in the waiting rooms of the emergency rooms with rape victims while I was doing my internship. And it just happened that at that time, the National Center for Mental Health, National Institute for Mental Health, decided to allot $3 million, which was a lot of money back then, to study rape. And so my supervisor, Dean Kilpatrick, suggested maybe we should try looking at the effects of rape, because everybody was saying, like, what's the big deal? Like, why is that a problem? Isn't that just sex? And so we wanted to show them, no, it wasn't just sex. We were looking at anxiety and fear and that kind of stuff, and doing a longitudinal study, and then starting to do a bit of treatment. And then I went back to finish my degree at the University of Georgia. And another person, Karen Calhoun, asked me if I also wanted to work on a grant looking at depression. So we submitted 2 grant applications, and they both got funded. So in the meantime, I had taken a job at the University of South Dakota. So I was flying back and forth for the next 4 years between the University of South Dakota and either Charleston or Atlanta to work on these longitudinal studies. And that's what got me interested. I started out in child and doing parent training and stuff like that. But like everything we learned was absolutely unknown at the time. So everything was publishable. Everything was of interest.
Let me pause if I may for a second here. So you said when you were an intern, you kind of got thrown into this experience or dove into it. I mean, and that's pretty intense. I mean, just to be sitting in the middle of the night with people what was that like for you?
It was very strange. Because people, I mean, first of all, they made them wait for hours. And it was like, if you bleed, you lead in the newspaper world. Same thing in an emergency room. So a rape victim is sitting there, like maybe crying, but maybe in shock. And so very often they got put in last place. And most ER physicians back then and nurses did not even know how to do a rape exam. They were often treated very badly. People would say horrible things. I remember one man running in looking for his wife and say, "What did they do to me?" What did they do to you? So, I mean, it really let me know that people knew nothing about the topic. And that fired me up. First of all, to find out what are the effects. And then second of all, how do we treat it? And this is before there was a PTSD. PTSD wasn't determined to be a diagnosis until 1980, and I started in the mid-70s working on the problem. So, as I said, we were right at the very beginning of trying to figure out, how this trauma affected women.
Wow, fascinating. So, how did things unfold for you? How did you conceive of putting together a treatment for this?
Well, we had tried a couple of other treatments. We tried something that was called stress inoculation treatment, which Mike and Baum had developed, which is kind of a problem-solving kind of treatment. And then when I got to the University of Missouri St. Louis, I looked at that and compared it to kind of just a general psychotherapy, and I just wasn't happy with the results. I also didn't think of it as an anxiety disorder anymore because I had worked with enough rape victims who said, I didn't think he was going to kill me, but because it was my husband or my boyfriend or whatever, but I was so humiliated. I was so betrayed by that person. And so they were feeling shame and guilt and all sorts of other emotions that were not fear and anxiety. So unlike some other people who were looking at treatments for PTSD as an anxiety disorder, I went the other way and was studying the work of Aaron Beck and his cognitive therapy for depression. Mm-hmm. And so that's how I ended up developing CBT, because he wasn't working with PTSD, but I thought this fits better, having people look at their thoughts and having them look at their, no matter what emotion they're feeling, whether it's fear, anxiety, anger, sadness, guilt, shame, across the board, we can work and do a cognitive therapy with them. And you change their thoughts, you change their feelings, and then it worked.
So how did you begin working with patients? If you can maybe share some early examples of what you did.
Well, we were studying rape victims when I was in Charleston, still on internship. And as I said, doing the rape crisis counseling. I didn't actually start seeing patients until I got to the University of South Dakota. And I saw a few up there, low population. So when I was looking for another job, looking to move, I actually looked for a job that had a high crime rate. So I ended up moving to St. Louis. Any city of 2 million or more would have done the trick, but they happened to have a job opening at the University of Missouri St. Louis that year, and that's when I really started doing the treatment work. We had a clinic; it was a clinical psychology doctoral program, and they had a clinic there, and that's when I started actually doing the treatment and experimenting with like what actually works, like measuring what you're doing, which had been part of my training.
So, what did you do specifically?
Well,
early on?
Early on, as I said, we were looking at problem-solving skills. We were looking at some other kinds of just general psychotherapy kind of stuff, and I wasn't happy with the results. There was no difference between them, and I wasn't happy. But that's when I started moving over into the cognitive therapy. And at that time, Aaron Book's book on treating depression was one of the first manuals, but it was too vague for me. I wanted something that was going to say, session 1, do this, session 2, do this, session 3, do this, and make it really systematic so that anybody could pick up the book. And if you knew how to do cognitive behavioral therapy, you could just pick it up and do the therapy. Now, obviously, there's a lot of people who haven't been trained in that. So we have a whole training program now where we do workshops and do consultation, 20 sessions of consultation while they're, to make sure that they're doing it correctly and with good fidelity and things like that. But by the time I got my first big grant to study that, and I was comparing it to prolonged exposure, which had come out about the same time that Edna Foe was, and she was doing exposure therapy, and I was doing a cognitive therapy. But that was 1994 by the time I got that grant. I had already done pilot work on 84 women on CPT before I ever got that grant. So I had a lot behind me, and I had graduate students doing it as well, and we really thought it worked. So then we were able to convince NIH to give us the money to do this controlled trial.
Early on, when you thought that maybe you should systemize this, session 1, session 2, for example, can you walk us through what the early stages of your ideas of, okay, session 1 should be X, Y, and Z? What did that look like?
Well, as I said, I had a lot of pilot cases first. I mean, usually you start with education. And so the question is, why do you have PTSD? Because lots of people don't get PTSD after a trauma happens to them. Sometimes they already had PTSD and this just made it worse. Sometimes there's something about the trauma itself that they can't get past. And the concept that I had was this: there's something getting them stuck in their natural recovery. And so we started thinking about the thoughts that they're thinking, the conclusions that they've come to as being what we called stuck points. And so a stuck point would be, this doesn't fit in with my prior beliefs. If I think that the world is supposed to be just and good things happen to good people and bad things happen to bad people, then this horrible thing happens to me. Well, I'm a good person. This doesn't fit. And so now you've got conflict. So we were seeing it as kind of a failure to accommodate to this event. It's too big and it doesn't fit your old beliefs. On the other hand, sometimes people had a lifetime of abuse. From the time they were little, they were being physically, sexually, and emotionally abused. This event might fit right in, and they might not have new PTSD, but they might have already had PTSD.
Wow. So the way what you're articulating now is huge. I mean, right. I mean, just the way you're saying it, it sounds, we've all heard that now, but at that point in time, I mean, to recognize that, hold on here, this, you're getting stuck. This is conflicting with your belief systems. I mean, these are really major discoveries. I'm curious, Patricia, for you, the thought that some of these people were experiencing sexual abuse and rape, and realizing that, how could someone do this to me? How the feeling of betrayal and shame, what was that like for you personally, witnessing that, being in that room?
Well, I mean, I learned very quickly, you can't tell somebody it isn't your fault. And so then, listening to their stories, I also had learned very quickly that you can't start feeling their feelings for them. You have to stand back and think about, how did they get stuck? What's interfered with their recovery? Because I was thinking of it, there's other disorders that people develop over time, but PTSD is something we think of as something blocked their recovery. Because there's a lot of people who do recover over a period of months. So what blocked it? What's gotten in the way? So I was specifically looking for places they got stuck in their recovery. And that most often it's a thought, it's my fault. I should have done something different. If only I had done this, it wouldn't have happened. So they keep going back and trying to redo the event and make it come out differently. Or making some kind of an assumption that it's something about them personally that had happened to them. But I also discovered very early on, you just can't convince somebody of that thought that they've been living with for a long time. So that's when we developed doing Socratic questioning, meaning you ask them questions that are going to lead them to a different conclusion.
What is specifically, what would that look like for someone?
Well, if somebody says, let's start with the rape victim. Let's say somebody says it's all my fault that it happened. Then I say, okay, so what did you do? Well, I had a drink that night. Okay, so how did that drink allow that person to rape you or cause that person to rape you? Did you ever have drinks and didn't get raped? Do you know if anybody else has been raped and hadn't had a drink? So you can ask all sorts of questions. What was your intention when you went out that night? Well, I was out with friends and we were just there having a good time. It was Friday evening and so on and so on. So we kind of walk them through the reasoning that I'm thinking in my head that they're not, because they're focused on I had a drink, so therefore it's my fault.
And well, obviously you did, but I was going to say, did you find that successful? It seems like such a challenging thing to do, because a lot, like you said, you can't change someone's thoughts, right? Just by telling them it's not your fault. I'm just curious how it unfolded such that you were like, okay, this is working. This is making sense.
Well, that's why we ended up developing these worksheets that teach them the skills of learning to explore and examine their own thinking. So the first thing you have to do is help them understand the difference between an event and a thought. Just because you think something doesn't make it true. The event is the rape. Now, what's your thought about it? What have you been saying to yourself? And when you say that, how do you feel? So then we had to help them think about different kinds of emotions and emotions. And if you change a thought, your feeling might change. So we use neutral examples, et cetera. Then we move on to teaching them we start doing the Socratic questioning and dialogue with them. And then we start handing the therapy over to them very quickly. Giving them a list of questions to ask themselves about a specific stuck point. They'll come up with a stuck point log. We have them do an impact statement, and where they write down not what happened, but why do you think it happened? And then how do you think it's affected you in terms of safety and trust and power and control, esteem, intimacy, some of these topics that are like, how's it affected your life now and into the future?
So it sounds...
They write all that stuff down, and then we start exploring, going through those thought by thought.
Yeah. Wow. I mean, it sounds like, in a sense, you, just by the very nature of what you were doing, it sounds like you were kind of disrupting their whole thought process, right? Just getting in there, but in the first place, and being willing to discuss what happened in and of itself was kind of a disruptor in a sense.
Right. And getting them to recognize that just because they think something doesn't necessarily mean I think something. So they'll say it happened because, and I'll say, so your thought is. And as soon as I say that, I'm not saying that's the fact. I'm saying that's your thought.
Right.
So that already starts to loosen things up a little bit. And when you say that, how do you feel?
All right, let's just pause here for a second to thank our sponsors. All right, we are back. Was the word trauma even in the vernacular at that point?
By the time I developed CPT, it was. PTSD was the diagnosis of PTSD came out in 1980. So, and I started really working on developing CPT in 88. So PTSD did exist. And so people were talking about post-traumatic stress disorder then. Yes, definitely. But there weren't many treatments at that point.
Let me just remind everyone, I'm speaking with Dr. Patricia Resick. Her new book is called Getting Unstuck from PTSD, Using Cognitive Processing Therapy to Guide Your Recovery. So tell us about this new book. Why did you write it? Who's it for, et cetera?
We had a treatment manual. We've had a treatment manual. In fact, we're just in the last stages this week of revising the treatment manual and sending it in. But there are so many people who can't get good therapy, can't afford therapy, or I mean, it's come out a lot, especially since the pandemic, that people's waiting lists are a mile long. And then to get people who are actually trained in CPT is particularly difficult. We have a website and people can look it up, but they contact people and they can't get treatment. And I've actually had people buy the manual and say, but this looks like a therapist manual. I say, yeah, it is a therapist manual. So I had suggested with a couple of colleagues that maybe we could write a self-help manual so that somebody could pick it up and walk through all those steps. Now, we don't call it session 1, session 2, session 3, because they're not doing this weekly. They're doing it maybe daily. So it's thinking more in terms of units or skills that they, this process they go through. So we teach them how to, some background stuff and how to assess their own PTSD, and then how to do that ABC sheet, the events, thoughts, and feelings, and then going from there, the questions to ask themselves, and so on and so on, and coming up with an alternative thought that's more balanced. So the whole idea behind the new book is that it is a self-help book for people who can't or are hesitant to go to a therapist. And so we're hoping that it'll reach more people who aren't going to get good treatment otherwise.
When you look back over at the arc of your experience thus far, compared to when you started, when you were first launched into sitting with women who'd experienced rape in the middle of the night, what are some of the things you think about what we as a culture know about sexual assault and rape and trauma and PTSD and how we're viewing it?
I wish I could say we've come farther than we have. I mean, I've been working in this field for 40 years, and I don't think the rates have changed at all. So I was hoping that people would start realizing that's not a good thing to do to somebody, whether it's doing it to a man, a woman, a boy or a girl, or anyone. I think as a society, we are more understanding of somebody when it happens to them. But I think we still have a tendency as a society to expect people to just get over it. Or conversely, sometimes people think, oh, PTSD, that means you're going to have it forever and you will never get over it. We're finding that most people can get over it, except for military, who tend to take a bit longer. And we could get into that for other reasons, but most civilians, and even I heard recently, first responders, they can get over it in 7 to 9 sessions. They don't even need a whole 12 sessions of therapy. It can be easily treated, even with people who have a lot of other symptoms, who have had a lot of trauma in their lives. Because once you change your thinking about your worst trauma, then it all starts to tumble down, and it changes the way you think. The analogy I sometimes will use with clients, or when I'm doing training, is that they've been going down this path, like going through a jungle, and they've been saying it so many times, and they keep saying it over and over and over, and it becomes the only path, and it leads them right into the muck, where they're feeling horrible about themselves. And I describe the CPT as giving them the machete, the tools to make a new path. It's going to take them to a whole different place. And that eventually that other path is going to get overgrown and not be the path they automatically take. So I think once you've got this other way of thinking, it then affects the way you think about lots of things, normal events in your life, other traumas that may happen to you. We've done long-term follow-ups 5 to 10 years later, and people don't relapse.
Wow.
Yeah. So, I mean, that's the fun thing about it. It sounds like it would be horrible to work with trauma or PTSD, but it isn't. It's, for a therapist, it's so gratifying because people get better and then they stay better, and it changes their life. Sometimes it saves their life.
Now, you kind of compared treatment for an EMT versus someone who's experienced rape. Is that discrepancy in terms of the length of treatment, the length of recovery, does that have to do with the fact that obviously sexual assault and rape, is it an interpersonal trauma?
And no, I said first responders also recover.
Oh, first responders. Okay.
Military people tend to not recover as well, but I think some of that has to do with their training. They're trained to go into war, and they're trained to be hypervigilant, which means when they get it back to civilization, they're not retrained to relax a little bit and just be normally cautious. They're still hypervigilant. They're taught things like, you are responsible for your men. So if anything happens to them, you're responsible. It's a built-in guilt maker.
Mm-hmm.
Or never leave someone behind. What if they had to leave someone behind? What if they couldn't save them? So there's this training, and it makes sense that they're trained this way, but unless they've got a lot of cognitive flexibility, it's hard for them to come back to civilization and be in the civilian world and just give up those beliefs. I think that's one of the things that's showing up now is that they need more, and they need probably more sessions, and they probably need maybe permission to give up some of those beliefs. I wish the military would untrain people when they let them go.
Mm-hmm. Well, what of the difference between the different traumas? Like when we talk about interpersonal trauma,
I think the content of the thoughts are different. The therapy doesn't have to be different, but when we do the therapy with somebody, everybody's unique. They come in with their own history. They come in with their own how they were raised by their parents, the kind of friends they have or don't have, their trauma experience, how people reacted when the trauma happened to them, whether they told people or they isolated them. And so everybody's unique anyway. But there's some events that are, with the military also, there's more likely to be head injury. And so we have to keep that in mind. Just like if we're working with battered women, there's very likely to be some head injury, and they may need more sessions or they need to do more repetitions of worksheets to kind of get it in there. Traumatic loss is another situation where people may have PTSD and they feel guilty that they should have saved somebody, or the suicide of a loved one, that they feel a lot of guilt and shame that they somehow didn't know or somehow couldn't save somebody. So that's what I think sometimes with first responders, it's a matter of helping them walk through that they really literally couldn't save that person. And it's kind of wishful thinking on their parts that they could have saved everybody. So interpersonal traumas are unique in that they've got somebody probably maybe they knew who did it to them, but maybe not. I had one rape victim who explained to me, when somebody turns on you and attacks you this way, they become a stranger. I went, oh, that makes sense. So maybe all rapes are stranger rapes.
So if I'm hearing you correctly, are you saying that there's not necessarily a difference in the length it takes for someone to be treated? It doesn't matter what type of trauma it is?
Well, we're trying to figure that out still. I think it would take military, active duty or veterans a little bit longer than it takes civilians, and that's the way it seems to be.
Right.
But even when we compared military and civilian women, it isn't a gender thing. The civilian women recovered more rapidly than the veteran women. They had gotten that military training. So I think in some cases, we're still trying to figure out what is it. Did they go into the military for a particular reason? Did they get trained in a certain way?
There's so many variables.
There's so many variables, and it takes a while to get that kind of untangled. But the nice thing about CPT is that it's based on like what they're thinking. Everybody has their own set of thoughts, their own set of ideas about like what caused it and what they should have done, and whether they're feeling scared or whether they're feeling angry or whether they're feeling shame or whatever it happens to be. We just base it on the individual. So it's although it's a structured therapy, it's tailored for every single person.
as we kind of wind down here, can you give us a thumbnail? I mean, you did it a little bit, but of what CPT is?
Well, CPT is a cognitive therapy, which means we focus on what they're saying to themselves about. We start with their worst trauma and then move on to other traumas they've had. Most people who come to therapy have had multiple traumas. One trauma, typically people don't go to therapy. They go to therapy when they've had many. So we try to incorporate whatever traumas they've had and help them explore through the questions that we ask. Does it make sense to say what you've been saying? Because they've gotten stuck. They keep saying the same thing over and over again, like a broken record. I probably shouldn't say record. Some of your younger viewers won't know what that is. Or a dog chasing its tail. I mean, they don't get anywhere, but they keep going back over and ruminating about how they should have done things different. And we try to break up that cycle by asking them very specific questions, not narrow thinking, but let's open up the picture. What else was happening? How old were you? How small were you? Who else was there? How far away was that person you thought you could have saved? Was it even possible? So we're asking a lot of those kind of questions and helping them rethink what actually happened at the time. And then once they start thinking about maybe I'm wrong in how I'm assessing this, then maybe that has implications for why I don't have to distrust everyone else. Because if the original event didn't have anything to do about trust, why am I distrusting all these other people, et cetera? Or if I think it was because I had bad judgment, does that mean I always have bad judgment?
So finally, can you share an early clinical error and what you learned from that?
Well, I've already mentioned a couple of those. Early clinical errors was trying to convince people that it wasn't their fault, and they'd look at you like you're crazy. You don't know, you weren't there. I think being too impatient. We have it laid out as a 12-session therapy, but when we do it as a variable length, it's anything from 4 or 5 sessions all the way up to 20-some sessions. And it depends on how quickly they can change, their own flexibility about things, how much they need to practice when we're working, as I said, with people with traumatic brain injury, or even the elderly who don't have the memories and they've been thinking the same way for 60 years. It may just take them longer. To kind of change the way they think. They're not going to, younger people are going to have that aha moment. And they go, oh, okay. And they change their thinking. Somebody who's been thinking that way much longer is going to have more trouble. And it'll take a lot more practice.
Right. Awesome.
So being impatient and thinking they should get, the first time you work on a thought, that they should change it.
The name of the book is called Getting Unstuck from PTSD Using Cognitive Processing Therapy to Guide Your Recovery. Dr. Resick, where can people get this book, first off, and then what's the best way for people to get in contact with you?
Okay, first of all, they can either get it from the publisher, Guilford Press, or they can look it up through Amazon or any other bookseller.
Wherever books are sold.
Wherever books are sold.
Right.
And contacting me is patricia.resick@duke.edu.
Okay. So your email there.
And our website, if they're interested in just learning more about it, is CPT for PTSD, all small letters and stuck together, .com.
Okay. So this is, I mean, like I said, an honor to have you on here. To talk to you who've created this major modality in the treatment of trauma. What's next for you?
Retirement. We're rewriting the main therapist manual. It's been out for a while. We've learned a lot since then. We're simplifying worksheets, et cetera. We're making it match the self-help manual. I've got another textbook I'm working on, wow. And then writing up lots of research findings. Well,
awesome. Inspiring. Pleasure having you on here. I want to thank you so much for taking the time.
Thank you.
All right. Take care.
Bye-bye.